Good morning, everybody. I'm really excited to be here. This is my first learning session, and it's been an absolute blast, so thank you all so much. I just want to go over a couple disclosures. So this presentation is part of a Vertex Pharmaceutical-sponsored speaker program. I do want to acknowledge that I developed this content in collaboration with Vertex, and these are my other disclosures at the bottom of the slide, but I like what Marissa just said. The disclosure I need to make is that I have PWD before my MD and before my PhD. I was diagnosed in 1987, and so this is, all these topics are very close to my heart, and I'm grateful for all the quality improvements that are really changing how we deliver care for folks with diabetes. So let's talk about why it's so important to stay aware of severe hypoglycemia. This is just a general outline of my talk. We're going to review the prevalence of severe lows, understand how they can compound the burdens of living with type 1, learn about associated risks, and finally, understand that there's methods now to allow us to capture severe hypo events in the EHR. So let's start out by just going over what the definition of severe hypoglycemia is. And this is defined by the ADA as an event characterized by altered mental and/or physical status requiring assistance for treatment of hypoglycemia, irrespective of glucose level. And so really, it's critical to understand it requires need for another person for assistance. In pediatrics, this can be difficult. Kids always require assistance, so really drilling down on exactly what happened. Did you just hand them the juice, or did they need assistance in terms of getting everything done? But this is categorized as level 3, meaning the highest level of hypoglycemia defined by the ADA. So why is it important to know what the definition is? When we're seeing people for follow-up in clinic, we can all come into clinic with different ways of how we might define severe hypoglycemia. I've had people tell me, well, I didn't need to go to the hospital. I didn't need to go take an ambulance or call an ambulance. I didn't pass out. So it wasn't a severe hypo event. So I think just by starting the conversation and sharing that, if you have altered mental status, that counts, and I want to know about it. You're creating a framework where they feel comfortable letting you know that these events have taken place. So is severe hypoglycemia happening? I talk to providers and they say, well, this doesn't happen anymore. We have technology. That's not true. So this is a study that we published in 2024, and it was looking at individuals in the Type 1 Diabetes Exchange Registry and online communities, and we asked people to respond to a survey. We had over 2,000 people respond, and one of the things we'll note about that cohort is 90% were using CGM. We also had representation of every insulin delivery modality, injections all the way to automated insulin delivery. And what we found is that 1 in 5 people living with type 1 reported having 1 or more severe hypo events in the past year. Surprisingly, the rates weren't all that different between the AID and the other groups. The AID group was slightly smaller in terms of percentage, but it was still there. Technology has not alleviated this issue. Additionally, 11% of the people reported they had 2 or more severe hypo events in the past year. There was one individual who reported having 12 severe hypo events. I can't even imagine living like that. So in this situation, we can definitely understand that hypoglycemia can trap people with diabetes in a vicious cycle. This is a different survey now, and if you look at all severe hypo events, 13.5% of respondents from this survey accounted for 89% of all the severe hypo events that occurred. So this small portion of the pie making up the most contribution to these events. In addition to that, there's studies that show if you have mild hypoglycemia as compared to somebody who has no hypoglycemia, over the next month's time, your risk of a severe hypo event is 8.5 times higher. And you know it, I have weeks where I'm like, oh, I'm having a lot of hypos. I need to be more aware. I need to be more vigilant, right? So it's plaguing people on a daily basis. So when during the day does a severe hypo occur? And so this is data that was collected from the CRASH study, where they took individuals who had a severe hypo event in the past 3 years, and they inquired about a number of different things. We'll go over a couple data points from this study throughout the presentation. But they found that 23% of the events occurred in the morning or the middle of the day, 21% occurred in the afternoon, 28% in the evening and before midnight, 27% occurred after midnight. So what shocked me about this is it's really equally distributed across the day, right? So in my mind, it was much more certain times of day. Now you will note that a third of the respondents reported they were asleep at the time their severe hypo events occurred. So it's not surprising that many people living with diabetes identify as having significant high fear of hypoglycemia. So in this survey of nearly 500 individuals, 30% indicated that they had high fear of hypoglycemia. When they asked these people when were the times they most likely experienced these episodes of having fear related to hypoglycemia, you can see the data here in the chart. So on the right-hand side, you see agree and strongly agree in the darker shaded blue. So times that people indicated, they said when I'm driving, when I'm sleeping, when I'm out in public. So nearly 50% of individuals reported those three things. People also indicated that they were afraid of having a severe hypo event at a time that others would not be around to help them. And that's definitely scary. In addition to that, we also see that some behavioral modifications were taking place amongst these individuals. So 43% said, I'd eat a little more so I avoid having a low blood sugar. And then over 20% said, I limit my physical activity or I keep my blood sugars higher. So we're not achieving glycemic targets because we want to avoid the potential of having a hypoglycemic or severe hypoglycemic event. And it's not just the individual with diabetes who experiences these issues. Again, we're looking at data from the CRASH study. And what we're seeing here is 184 people with diabetes represented in the darker blue, 140 caregivers represented in the lighter blue. And when they asked about the emotional impact of severe hypo events, 60% of the people with diabetes and 82% of the caregivers reported they felt scared from severe hypo. 40% of people with diabetes and a third of the caregivers felt unprepared for these episodes. And the majority of people with diabetes and 40% of caregivers acknowledge they felt helpless when these episodes occur. And we know severe lows can vastly impact the lives of people with diabetes. In this survey, they asked individuals, a total of 219 people, to tell about areas of their life that are impacted by hypoglycemia. And you see the list here. Work and studies, relationships and social life, leisure and physical activity, everyday life, sleep, sex life, physical health, mental health. That's everything. There is nothing that is not impacted by these concern of having hypoglycemia. And it's not surprising that people with diabetes, we make 180 decisions a day based on living with this condition. And it's because we're thinking about how we can navigate through life and not allow the condition to impact us. And burnout is extremely common. I really appreciate what Tina and Marissa said. One of the things we know is that, let me first define diabetes burnout. So it's a combination of mental, emotional, and physical exhaustion, feelings of detachment, and a sense of powerlessness to manage diabetes or to retake control of diabetes. Now, my feeling is that if you ask people with diabetes on the right day, every single one of us has diabetes burnout. There are days I wake up, I tell my husband I'm done with this, I don't want to have diabetes anymore. He says, I understand, I'm here for you, let's go about the day. And that's just where we stand. But when they asked in a survey of 100 people, 55% reported having burnout related to daily type 1 management on most days. So that's more than half the respondents. And 36% indicated that diabetes burnout is a major barrier to their diabetes management. So truly significant issues, and I think it's important when we have time, ask people about how they're feeling about their diabetes. Where do they stand in terms of that sense of feeling overwhelmed? Allow them to share that story with you. We also understand that severe lows can have serious health consequences. There's a 2-time increased risk of cardiovascular disease associated with severe hypoglycemia. And data from EDIC, which is the long-term follow-up of DCCT, showed a history of greater than 1 severe hypo event can result in significant decline in psychomotor and mental efficiency. And we know that the ADA warns that a severe hypo event can progress to loss of consciousness, seizure, coma, or death. And this issue with the life-threatening nature of severe hypos has been well documented. Risk of mortality increased 3.4-fold in 5 years following a severe event. And in addition to that, when looking at predictors of mortality for individuals with type 1, having 2 or more severe hypo events that required hospitalization was the strongest predictor of time to death. And we also have to recognize that these events may be underreported by people with diabetes. Again, looking at data from the CRASH study, 50% of people with type 1 did not discuss their most recent severe hypo event with their healthcare professional. Why didn't they do it? 54% said, well, I know what caused it, so it's fine. 24% said it's not a big deal. I am shocked. How are we saying severe hypoglycemia is not a big deal? Now I'm going to share a story with you. 12 years ago, up until that point, I was saying, I've never had a severe hypo event, right? This does not happen to me. But I was working on the nasal glucagon study prior to approval, and I'm writing up the paper, and I'm writing down what the definition of severe hypo is. And I'm like, darn it, it's actually happened to me. At the time, it was exactly 12 years ago, I had my newborn son, I was walking through my house, and I felt really weak, and I sat down on the floor, and I laid him on the tiles on the kitchen floor, and my daughter came into the room, and she says I struggled to say words. We have a very clear jar that has hypo treatment available in it. And so she got it for me, I treated, I felt better. Now in my head, I had not had a severe hypo event. Why? I didn't pass out, I didn't have a seizure, I didn't take glucagon. And in addition to that, nobody asked me about it, right? And the other component of things is, as a person with diabetes, I don't want to acknowledge that I have this occur to me. I feel judged at times, like I'm not doing well with managing my condition. I'm doing well, this disease is the problem. And so I think allowing people, again, to be open about what's happening, asking them every single time will afford that opportunity to learn more about what's happening at home. And we know from a follow-up study that hopefully will be published shortly that when we looked at those 2,000 individuals who responded to that initial survey, we went back and asked them to respond to a repeat survey. And we got about 50% response. We saw use of technology increased. About 17% more people were using automated insulin delivery. Rates of severe hypo, rates of impaired awareness of hypoglycemia did not change. But this time around, we wanted to understand where were these severe hypo events occurring. And 89% of these events occurred at home. People never made it to the ER, they were never hospitalized. And when we asked people what caused the severe hypo event, 61%, well, I miscalculated my insulin. I overestimated my carbs. We clearly know automated insulin delivery systems can't overcome that. The other 2 most common endorsed issues were physical activity or my meal was delayed. So again, this can happen to any of us. It happens on a daily basis, and so creating and setting that stage to talk about it is critical. So how do we do this? I think it's really important to let people know you want to hear about these events. And I encourage people to contact us in real time. Why do I want to have that phone call into the office? Because we'll reduce insulin doses over the next 24 hours. I'm going to make sure you have another glucagon emergency kit available at home, because we know in that first 24 hours you're at highest risk. Sometimes people don't want to call in. Maybe they want to send a message through the portal following an event. This worries me. I've had 2 reports in my chart from people saying, in all capitals, "Oh my gosh, my child just had a severe hypo." And I'm like, okay, this is not the way to tell me about it, right? Call me. I want to hear. Shouting at me on my chart is not helpful. And then finally, asking people to go ahead and log these events, write it down. If you don't want to tell me about it in between visits, just make sure to talk about it at the next visit. But if I bring it up, you're going to be more likely to remember what occurred. So what are the possible benefits of recording these episodes? First off, we want to capture how frequently this is happening, right? So we need to talk about it, we need to document it. It'll also allow us to flag and keep track of individuals who we need to have continued follow-up discussions. And recognizing, again, that there's a certain subset of people who have repeated episodes of severe hypo. Just like DKA, we're looking at, oh, you've had repeated episodes of DKA. I need to be doing the same for severe hypoglycemia. I want to record these events to make sure people can have access to technologies and therapies that will allow them to go ahead and avoid future episodes of severe hypoglycemia. And finally, I'm sure many of you are in the same position as me, where I have these long-winded conversations. I should document it in the EMR. I should identify the amount of time I'm spending on the telephone, because I need to, again, say, hey, look at all this work that's going in here. I'm valuable. The work I do is valuable. It needs to be recorded to recognize it's going on. Another way that we can recognize that this is going on is by capturing the severe hypo events in the EMR. And just last year, there's a new ICD-10 code that can be used. And the one I would point out here is E16.83. That's a code that we can use to indicate someone's had a severe hypo event. This way, it's recorded on the chart. We make sure that we're asking about it again in the future, checking in, do they have glucagon, and again, providing access to technologies and therapies as they become available. One thing I like to do, I don't know about you guys, I love to have it in my favorites category, because if it's not there, I'm not documenting it. So I definitely encourage that. So I'd like to thank you all for your attention and encourage you to continue to empower people with type 1 in your practice to report their severe hypo events. If you'd like to learn more, Vertex has created Spotlight on Severe Hypos, and you can get there from this QR code, and I'd be happy to take any questions.
I can, thank you. Hi, Christy Curley from Grady Health System. I love that you are encouraging patients to actively let you know so that action can be taken right away. But how do you keep up with those calls? Do patients have access 24 hours a day to someone? Okay, who could give advice?
In our clinic, absolutely. Okay. So we have a 24/7 call line that they can reach out to. It's staffed by our advanced practice providers, our physicians, as well as our fellows. So it's definitely a team effort to get all that coverage available. But even if people call, a day later, that's okay, because you can still give guidance. I mean, one of the most important things I think we do is say, do you have another prescription for glucagon? Let's cut back those insulin doses. Or if they haven't figured out what may have caused it, walk them through what occurred. So whether it's 24-hour call or the next day.
Or the next day. Thanks so much.
Yeah.
Hi, Lauren Golden from NYU on the adult side. That was great, thank you. I have a subset of folks that I care for who I think have possibly a phobia of hypoglycemia. Maybe it's beyond just a fear. They have really tight control, it's just high.
Yes.
Right? So a low coefficient of variation, but everything is 200. And we've struggled to really both try to help them acknowledge it, and also sort of who to refer them to help with it, because they don't actually necessarily acknowledge the issue. We don't have social work or psychology on site, and I'm not even sure if psychologists would identify how to handle this without being blameful. But it does seem almost to have gotten beyond just fear. So I'm just curious if you have any insights about what to recommend for that.
I definitely think we have folks like that, people who we'll see in clinic, and number one, maybe are on just intermittent glucose tests, and then we put them on a CGM, and I'm like, oh, look, 95% time above 250, okay? And so talking about why that occurred, and then setting realistic expectations, I'm like, I just want you to move 5% down, right? Like, I'm not asking you to go all the way down to 70 to 180. Let's just get to like 180 to 250. And talk about the way that the highs can impact their everyday life. So I'm a pediatric endocrinologist. I'll say to kids, like, again, this is more of my own issue. I'm mean when I'm high. My family acknowledges this. If I get in a fight with somebody, I've got to test and show them it's on, because I can definitely get a little bit more afraid. And so I talk to kids and I'm like, do you find that your mood is impacted? And they'll be like, no. And the parents in the corner going, yes, right? And so then you can bring it to a point where, okay, well, how is this impacting day to day? Do you find, let's see if you feel a little bit better if we bring you down. So just taking it in steps. And then even as we hopefully adopt automated insulin delivery systems for these individuals, thinking about ways to make that transition more steady, allowing them to know that you may have symptoms of hypoglycemia because your body has reset its thermostat. So, take some carb-free foods. We don't want to propagate this vicious cycle of keep me high. So little strategies like that. I'll also say things like, and I'm going to give a shout out here, and you guys are going to tell me if I'm right or wrong, Blue Circle Health, that can provide some of the, support for these individuals in the states where it's available. I don't know the states, but I think, I recognize, we have folks on our team. I don't have enough staff. I've watched some of you come up here and list what your staff is like, and I'm just like, crying, right? Because I feel so under-resourced. So I think looking for methods to find people outside of our clinic that can help us out in these moments is great.
So I'm Mary Lauren Scott from UAB in Birmingham, and I deal with a lot of high-risk pediatric patients, and I find it's sort of an unspoken elephant in the room in all of diabetes care that there are two types of patients that are on high-dose insulin. One of them potentially has type 1 with some obesity or insulin resistance. The other are non-adherent patients who get iatrogenically overdosed because of failure to communicate. And so I think I find in that population, my approach has been to be honest with them as I see a thin kid with an A1C of 12 on 2 times their body weight in kilos of basal insulin, that I try to hear them and be transparent, and then also let them know as a medical professional what I'm seeing. So if they're still saying I'm taking all my shots and can't disclose errors in dosing or struggles that they're having, I tell them, I can go up on your insulin. However, it worries me because it's getting so high. I want you to know that if something changes and you start having lows, to communicate that. But I feel like that happens so often to our patients, and I worry that maybe they're not always getting that honesty side of the communication from their provider, so they don't understand potentially how at risk they are. And I think that's something that I feel is important, because you'll see as they do start to improve with their burnout or whatever they're struggling with, they'll start to see lows, and they understand why better, and they can communicate that to you, and you can make changes.
I think that's great. Oftentimes when I have kids who I calculate the total daily dose and it just seems excessive, I'll say, can you tell me how many shots you miss in a week? Or I don't let them say yes or no. I just ask for a number. And it's amazing how just reframing that way and allowing them to let you know. And then the other thing I'll say is this is where recognizing insulin resistance and obesity can definitely be contributing to some of this. I'm excited for the GLP-1 breakout and how that's going to impact care delivery for individuals with type 1. The final thing I'll say is I do recognize we get a lot of calls in our group of like one parent dosed and then the other parent came in and dosed, right? And we're like, great job, guys. Everybody's really on top of it, but like, let's work together. But it happens. Life is busy, so allowing those conversations to occur, recognizing that there's missteps and it's okay is important. I think I saw somebody else with a mic. Sorry.
Hi there, Jen Riley from Children's National in DC. And I apologize if I missed this, but you mentioned that a series of lows increases the risk for a severe low event. Do we have more of a definition of what that means? Is it 2 lows a day for 3 days, or is there any more specific? Just
in
as
the
patients
paper,
ask?
it really just indicated if somebody's having mild hypoglycemia. So as compared to somebody who maybe is spending no time below range, again, those folks who are having some time below range, which we all have some time below range, it's going to increase our risk. So I truthfully believe that's why it's important, regardless of where somebody's at, talking to them about severe lows is so important, because we know they're having it, right? Whether or not they're telling us.
Excellent. Thank you so much.
Yeah.
Hey, Jen. That was a wonderful presentation, and I want to thank everyone in the group for commenting on these really scary topics. Unfortunately, we see a lot of people in similar situations living with both very persistently high or actually persistently low blood sugars. A lot of it may be due to the fear of complication and avoiding that, or the fear of hypoglycemia. So I think that there's that emotional and the fear component for sure that we're all aware of, and we would like to work to address that, but as was brought up earlier, that's probably very difficult, and how we do that is not clear yet. The part that I'm wondering is I'm starting to have concerns that we're missing really big cognitive problems that are also coming along with that. We have very intelligent, functional people who are missing some pretty big things, and I'm concerned about how to identify that. And I'm wondering if anyone has gone down the path of having a cognitive evaluation for some of the patients. I mean, I have somebody with a time below range of over 30%, and I don't know, what impact that has.
I think that's a great question. As a pediatric endocrinologist, I have not sent people for cognitive testing, but I think just, talking about the fact that, we anticipate, there's a paper that was published this past year, and I can try and send it out if people are interested, but it showed that they looked at reaction time when people were low and when they were high, and it shows that the timeline of reaction time was definitely impacted. So just talking to people about like everyday events, you're going to get in your car, you're going to start driving, right? And so whether or not we're doing a bigger cognitive test, but you're getting behind the wheel. I've talked to kids and said, you're behind the wheel, I'm in the next car over. That scares me, right? And I think, again, just grounding things in everyday situations may help them figure out. But I don't have a great answer. It's a great question, though.
Hey Jen, this is Viral. Great presentation. And then a couple of comments, or probably my summary of some of the research that I think I came across. One thing is that I think you mentioned this very nicely, is a normalization of those severe hypoglycemia event, I call it, right? So when we surveyed our people with type 1 diabetes back in Colorado, and our interest was to understand what happens, or whether do they have a hypoglycemia while they're driving, right? And 72% of people reported that they have at least the one hypoglycemia while driving at least once in a year. That's a lot, right? And about, I think, if I'm not wrong, 10% of those events led to some kind of a car accidents. And not a single one wanted to report that as an hypoglycemia leading to car accident, right? So it's a big issue. And then what fascinates me is that I think I was reading a research that these people did from the Europe, and they put these people in a simulation while they're driving a car in a simulator, and they induce the hypoglycemia. And the most common mistake they made is that putting a more pressure on a gas pedal than the brake pedal.
Yeah, I've seen that paper. It's
Beautiful, right?
Yes.
And so I think one of the hypotheses is that the spinal reflex, the day-to-day function that we do is through spinal reflex, and you are likely to make more error that you do more commonly, right? Mm-hmm. So we do more pressure on a gas pedal than the brake pedal normally. So during hypoglycemia, your brain is not functioning. It's right. The spinal cord is just giving you that message, just do that. And so I think there is a lot of things to learn in this area, at least in the adult world. On my side, I do see a lot of patients with so-called geriatric diabetes, and we do cognitive assessment. It's very common when you see that kind of an ups and downs in older individuals. We do send for cognitive assessment, and there is no surprise you will see that they do have some kind of a cognitive impairment. Just my 2 cents, but this is a topic that I think we need to talk more about. Yeah.
Thank you so much.
Hey, I just wanted to bring up that as we're all aiming for tighter range, just because it doesn't say time below range doesn't mean the lows aren't happening, because a lot of people really are trying to prevent lows during the day. We've talked a lot about it in our practice with people with diabetes, that they are nibbling throughout the day. They are heading low, or the sensor hasn't picked up on it, but they are symptomatic. So I think that sometimes when we're like, oh, they're not having a lot of lows, and we glance at it, it's actually masked a little bit of what's happening to prevent those lows. So it is good questions to ask of like, do you feel like you need a snack during the day? Do you feel like you need to eat something so you're not going low? Are you getting a lot of alerts that you might go low? Because I do think as we aim for tighter range, we are having a lot of those behaviors have to happen.
I think that's an excellent point, and especially for individuals on automated insulin delivery, I love to show them, look, you actually caused increased insulin delivery with that snack you ate, because you can see that like they come down and then all of a sudden they're bouncing back up, and I'm like, did you eat here? Was it because you felt a little low? Let's use a carb-free food next time, right? Because again, grounding things I think in data helps the story about why it could be problematic with the behaviors we're adopting, but that's a great point. Thank you all so much.